Welcome to our comprehensive guide on superior limbic keratoconjunctivitis, or SLK, a chronic inflammatory eye condition that, while not blinding, can significantly impact your quality of life. We'll explore its causes, symptoms, diagnosis, and available treatments to help you understand and manage this often overlooked condition. The exact cause of SLK remains somewhat of a mystery, but several factors are believed to play a role. These include mechanical trauma from blinking, particularly in individuals with tight upper eyelids, thyroid dysfunction, with a strong association to hyperthyroidism, and possibly tear film instability or autoimmune mechanisms. Contact lens wear can also be a contributing factor, and in some cases, SLK may be associated with other systemic diseases. Essentially, it's likely a complex interplay of these various elements triggering the inflammatory response. The pathophysiology of SLK involves a cascade of events that ultimately lead to inflammation and damage of the superior bulbar conjunctiva and the superior limbus, the border between the cornea and conjunctiva. This inflammation results in thickening and redundancy of the superior conjunctiva, along with increased vascularity. The constant rubbing of the upper eyelid against the inflamed tissues causes mechanical irritation, epithelial breakdown, and the formation of filaments on the cornea, further exacerbating symptoms. Microscopically, we see an infiltration of inflammatory cells within the affected tissues. SLK is considered a relatively uncommon condition, and precise epidemiological data are limited. It appears to affect women more frequently than men, and the typical age of onset is between 50 and 70 years. However, it can occur in younger individuals as well. While SLK has been reported worldwide, there are no known specific geographical or ethnic predispositions. Its true prevalence is likely underestimated due to frequent misdiagnosis or under-recognition of the condition. The signs and symptoms of SLK can be quite bothersome. The most common symptoms include persistent eye irritation, a foreign body sensation, burning, stinging, and excessive tearing. Patients often report redness, especially in the upper part of the eye. Other common signs include photophobia, or sensitivity to light, and blepharospasm, which is involuntary eyelid twitching. A defining feature is the superior bulbar conjunctival injection, meaning redness specifically in the upper part of the white of the eye. The presence of corneal filaments, tiny strands of epithelial cells clinging to the cornea, is also a characteristic finding. Diagnosing SLK primarily relies on a thorough clinical examination by an ophthalmologist. The doctor will carefully evaluate your symptoms and look for the characteristic signs, such as superior conjunctival injection, papillary hypertrophy in the superior tarsal conjunctiva, in the inner lining of the upper eyelid, corneal filaments, and superior corneal punctate epithelial erosions, tiny erosions on the surface of the cornea. Rose bengal or lissamine green staining are often used to highlight the damaged areas of the conjunctiva and cornea, making them more visible during examination. In some cases, a thyroid function test may be ordered to rule out an underlying thyroid disorder. While SLK is not formally classified into different types, some clinicians distinguish between SL associated with thyroid disease and SLK without thyroid involvement. Additionally, the severity of SLK can vary significantly from mild irritation to more severe, debilitating symptoms. This variation in severity influences treatment strategies. Treatment for SLK aims to reduce inflammation, alleviate symptoms, and promote healing. Options range from conservative measures to more aggressive interventions. Artificial tears and lubricating ointments are often the first line of defense to provide comfort and protect the ocular surface. Topical corticosteroids can reduce inflammation, but their long-term use needs to be monitored due to potential side effects. Topical mast cell stabilizers and nonsteroidal anti-inflammatory drugs, or NSAIDs, may also be used to control inflammation. In some cases, a mild silver nitrate solution can be applied to the superior conjunctiva to debride the abnormal tissue, but this is performed with caution. Punctal plugs, which block the tear ducts, can help retain more moisture on the eye surface. For severe or recalcitrant cases, surgical options such as conjunctival resection, removing the affected conjunctiva, or cauterization of the superior conjunctiva may be considered. If thyroid disease is present, managing the thyroid condition is crucial for controlling the SLK. Currently, there are no definitive preventative measures for SLK. However, individuals with a history of thyroid disorders should ensure they are properly managed. Maintaining good ocular hygiene, avoiding excessive eye rubbing, and using artificial tears regularly, especially if experiencing dry eye symptoms, may help to reduce the risk or severity of SLK. If you are a contact lens wearer, following proper lens care and hygiene is paramount. The prognosis for SLK is generally good, although the condition can be chronic and relapsing. With appropriate treatment and management, most patients experience significant symptom relief and improved quality of life. While complete resolution is not always possible, Persistent adherence to the prescribed treatment regimen is crucial to minimizing recurrence and controlling symptoms. Recent research is exploring newer anti-inflammatory agents and alternative surgical techniques to improve outcomes for patients with severe or refractory SLK. Further investigation into the underlying mechanisms of SLK may lead to more targeted and effective therapies in the future.